Today's pre-recorded webinar offers strategies for implementing the CDC guidance for childcare programs that remain open. The version of the CDC guidance is dated April 21st, 2020. This information may be helpful to childcare programs which are currently operating, as well as those preparing to open in the future. The information is relevant to childcare centers and group childcare homes, as well as family childcare homes. And today is Thursday, May 14th, and this is the third webinar in our series. So welcome today from the Office of Child Development and Early Learning, the Bureau of Certification, and the Pennsylvania Key. We sincerely appreciate all of your hard work that you do every day to keep everyone safe and healthy. Thank you so much. Today's webinar recording will be posted on the PA Keys coronavirus webpage with slides, and the weekly webinars are pre-recorded so you can access future webinar recordings on demand at any time. The content of these pre-recorded weekly webinars is different every week in response to your questions. Please email your questions to hssco@pakeys.org. We really need your questions in order to meet your needs, so please continue to submit them. And if you notice that your question does not seem to be addressed during today's presentation, please email your question again to hssco@pakeys.org, and we'll do our best to get to it. Thank you. As counties move from red to yellow phase, it is a local child care decision whether to reopen. We hope that this information provided today and in the other webinars will help you plan operations and make a decision that is right for your program. This is me. Okay, so today I will highlight portions, not all, of the supplemental guidance for child care programs that remain open. This is the guidance from the CDC. A special note regarding the guidance is that many stakeholders are looking for the Department of Health or Department of Human Services to issue guidance specific to Pennsylvania child care. The CDC guidance is the most current and updated information relating to COVID-19. As the CDC learns more about this virus, the guidance is the most trusted source of information. In addition to the supports available through the Departments of Health and Human Services, the Office of Child Development and Early Learning also is being advised by public health experts from the Children's Hospital of Philadelphia, better known as CHOP, a group of pediatricians and members of the PA chapter of the American Academy of Pediatrics, as well as health experts that are experienced in child care health consultation and technical assistance. The purpose of the webinars, of course, is to clarify practices that are described in the guidance and to describe how the guidance can be implemented to keep children, staff, and parents safe and healthy, and to address your questions. This is the position of the Bureau of Certification. The Bureau of Certification is recommending child care providers follow the CDC guidance to the best of their ability. The CDC guidance describes what programs should do. Child care operators considering reopening must familiarize themselves with this guidance. Please see the phased-in approach to reopen business, what it means for child care programs, the OCDEL announcement that went out on May 2nd, 2020. Today's webinar topics, May 14th, 2020, is more discussion about cleaning and disinfecting practices, exclusion and return to care criteria, screening of staff and children upon arrival, including COVID-19 symptoms and risk factors, drop-off strategies, and some frequently asked questions regarding the guidance on masks and cloth face coverings, which we always seem to receive many questions about. Just overall, it's important to recognize that all of this information is very new. So communication is absolutely essential. You must communicate with your families frequently. Update emergency contact information regularly. Inform them about your new policies and procedures. Offer ways to communicate with parents virtually. And of course, check in with families about their well-being. Share community resources, encourage them to keep their child's well visits on schedule. It's very important that we continue to have children attend their routine well child visits and receive their screenings and immunizations on time, because this is what will allow them to be healthy and ready to learn. So I'm going to talk a little bit more about cleaning and disinfecting. Overall, it's important to be doing more cleaning and disinfecting than usual. So upon entry into the facility, all adults and children must be hand washing or using hand sanitizer, which is greater than 60% alcohol. It's important to practice meticulous hand washing with children and to follow strict respiratory etiquette, avoiding the touching of your eyes, nose, mouth, or face. Obviously, children and adults often cough and sneeze, so it's important to cough into your inner elbow and to teach children how to do this rather than coughing or sneezing into your bare hands. Or you can use a tissue and, of course, dispose of the tissue immediately into a safe receptacle, and then immediately hand wash after blowing your nose or coughing. It's important to see Caring for Our Children, which is really considered our best practice guidance, the standards, in Appendix K on routine schedule for cleaning, sanitizing, and disinfecting at this web address at nrckids.org. A word about hand sanitizers. The CDC guidance says that you can use hand sanitizers on the children's hands when they first step into the facility, for example, or are being carried into the facility by a staff member, because oftentimes there's no sink for hand washing at the front door or outside the facility. So the other option is to apply the hand sanitizer, which is at least 60% alcohol, very carefully to the child's hands, and then rub it into the hands until the hand sanitizer is completely absorbed or dries. Usually this happens in less than 10 seconds. Or directly supervise the process of the child sanitizing their hands with older children if they are able to apply it themselves. The hand sanitizer, of course, must be stored away from children and kept out of reach due to its toxicity. So let's have a conversation about what surfaces should be cleaned. I wanted to say a few words about what that means. Cleaning is actually using soap and water to eliminate visible soil on surfaces of items such as toys, floors, clothing, cribs, cots, and mats, play equipment, and refrigerators. As you can imagine, these are frequently touched with our hands and probably have lots of fingerprints on them, whether you can see them or not. They could have visible soil on their surfaces. So you definitely want to clean with soap and water first to eliminate that soil, and then apply the disinfectant. Additional surfaces that should be disinfected are drinking fountains, doors, and cabinet handles. These are very high touch surfaces that have been soiled with body fluids, such as a diaper table or something like that. Mouthed objects, which collect, the saliva, you should put those in a tub and collect them right away after a child has played with them and is finished playing with them. Toileting and diapering areas, such as the diaper changing tables and the pails, the countertops in bathrooms, potty chairs, hand washing sinks and faucets, toilets, and bathroom floors. Right now, it seems that the bleach is readily available, although you may not be able to buy a lot of it at one time. It is relatively low cost and it is effective if it's used correctly. It's important to use an EPA registered disinfectant and mix it daily. So the bleaches usually require you to mix daily. That's important because we want it to be maximum strength. So be sure to follow directions on the label for disinfecting and how to make that particular solution. Label the bottle with the date and the product. Wear gloves and protective eyewear, of course, when you're diluting it, and mix it in a well-ventilated area. That's really important. Use a funnel when mixing to decrease the amount of bleach that's inhaled, and mix the bleach into cool water to reduce the fumes rather than adding water to the bleach. This is a very nice resource which I have visited quite frequently. It's the EPA-approved List N, and it has a list of all of the EPA-registered cleaning products that have been determined to be effective against the virus. So this is the specific website for that and web page. It's important to follow the product information on the concentration, the application method, and the contact times, as the contact times do vary, but most of these solutions require about 5 minutes of contact before they air dry. Always use caution with the disinfectants. It's important to provide ventilation. In general, ventilation is very helpful to our overall health. The fresh air, of course, in the facility is very helpful and will help to reduce concentration of the viral droplets as well. So we definitely encourage more ventilation. Remember that the disinfectants are toxic chemicals, so you need to hold the bottle at a safe distance away from the nose and mouth when spraying, and you really shouldn't be spraying that around children. Label the spray bottle dilutions with the product and the date that you have mixed them, and keep products out of the children's reach, of course, in a locked cabinet. More guidance on using caution with disinfectants. You need to wear personal protective equipment such as gloves and eyewear when you're mixing these chemicals, and disinfect the surfaces and the toys and things like that while children are not in the area. The surface should be dry by the time a child returns to the area or sits down at the table. And don't mix the products or reuse the bottles for any other different products. Never mix chemical products. We're not in chemistry class anymore, so we want to avoid that. A few of the things that will help you implement this guidance, and these are the strategies that I've learned about from programs that are in the middle of implementing them or who have been open for quite some time. It's very important to reduce clutter and shared toys from the facility, and this is done by keeping most surfaces clear of clutter. It's easier to clean and disinfect uncluttered surfaces. Just put away those items that you don't use on a regular basis, and put away toys that are shared by several children at once. Be strict about putting that mouthed or handled toy into a bin with disinfectant after the child touches the toy, and always keep it out of reach under lock and key. It's helpful if you can encourage parents to limit items brought from home. We really want to limit the transfer of items back and forth from the facility because that actually raises the incidence of the virus being transmitted back and forth. So we want to limit this. Avoid bringing in backpacks, toys, stuffed animals, anything like that. It's okay, of course, to bring a child's bedding in, any special blankets, a pillow, for example. You can bring those in, ideally, if it's possible, and laundry capabilities are available. we recommend that you wash the child's bedding, nap items, and soiled clothing at the facility rather than taking them back and forth. Overall, we want to avoid moving any items in and out of rooms because, again, this can transfer the bacteria to different locations in your facility. So you want to avoid that. And in general, limit transferring items back and forth to home. If parents are sending bedding and blankets or personal items, ask them to put them into a sealed bag. And of course, keep those bags away from the children. They should be stored up and away from their reach. But it is okay if they want to bring them in, to bring them in a sealed bag. It's important to be aware of the guidance on visitors, and it follows what I said earlier about bringing the virus in and transferring the virus from one location to another. It's important to explain to parents and others that your facility really is avoiding visitors of coming in. But if a parent insists that they want to enter, of course, they may have access per the licensing regulations. It's just good guidance to try to limit, if at all possible, the visitors that are coming in and out of your facility and potentially exposing your staff and children to more, airborne droplets of the virus as they come in and out. Right now, we have heard that there are no early intervention or EI staff that are going into childcare, even when in the yellow phase. So they're not going in, even when in the yellow phase in specific counties. If the childcare teacher agrees, the EI staff, of course, can do a tele-intervention with the teacher to support the child who's receiving these services through coaching and helping the teacher embed the child's IFSP or IEP goals into the regular routines of the classroom. And of course, we would encourage this to keep the child's individualization going when they're in the program. I'm going to talk about exclusion criteria and return to care guidance. Many questions have come in about when to exclude children and staff and when it's safe to return to care. And I'm going to talk about some of the more common questions that have come in. First of all, I'm going to go over, though, the symptoms of COVID-19. It's very important to be really familiar with these signs and symptoms so we can do our own health check on ourselves before we even leave our own homes. And staff should also be doing this self-assessment before they come into your program every morning or whenever they're scheduled to come in. As you can see, the symptom list keeps getting longer. It started out with just the first three, which is fever of greater than or equal 100.4 degrees Fahrenheit, 38 degrees Celsius. The cough is very symptomatic of the COVID-19, and it's often a dry cough and a persistent one. Shortness of breath or difficulty breathing. But more and more, we're seeing these other symptoms, which include diarrhea, chills, and or repeated shaking with chills, muscle pain, headache, sore throat, and an interesting one, which is that new loss of taste or smell. And lately, we've heard in the news about children with COVID-19 who have inflammatory disease called Kawasaki's. That's an example of this inflammatory disease. And many cases are appearing first with the gastrointestinal symptoms, such as nausea, vomiting, diarrhea, and stomach pain. So it's important to understand that children may not show the cough or the fever. They may actually show the diarrhea and the gastrointestinal problems first. So it's important to be aware of that. Before staff or children enter the facility, it's very important to do a screening and to exclude anyone who has one or more of these symptoms. A fever of greater than or equal to 100.4 degrees Fahrenheit, the dry persistent cough, which isn't a cough that you would normally have, trouble breathing, shortness of breath, rapid breathing, or difficulty breathing, or if a child is really irritable and they act sick, of course, you're not going to want them to enter the facility. Any chills or repeated shaking with chills, and again, the new loss of taste or smell. I know that you all have policies around the daily health checks, so you definitely need to continue these because any signs or symptoms of illness could actually be something other than the COVID-19. So you want to be aware of that and to do your daily health checks as you normally would. This is a question that has been submitted frequently. What about a fever? So I'm going to go through the steps that you would take to determine whether or not to exclude a child. So for a child or staff member that has not been tested for COVID-19, it's important to refer to the PA code for the existing licensing regulations on exclusion and return to care criteria. And the PA code does suggest exclusion for fever, and it's quite specific. This is the code link that I've provided to you. However, the return to care guidance is not as specific, except for infants under the age of 4 months, when it actually says in the code when the fever is resolved or judged to be non-infective. So, with consultation with some of our pediatric health experts and people that are very familiar with the infectious diseases in child care in schools, and given that the PA code is not specific about return to care for fever, we recommend that you check out Caring for Our Children, the 4th edition here at nrckids.org. And you can certainly use the guidance of Caring for Our Children for fever under influenza management, which is very specific. And this is the 3rd bullet. Allow children and staff who have been excluded for fever or respiratory symptoms and fever to return once the fever has resolved for 24 hours with no fever-reducing medications. So it has to be a full 24 hours without any Advil or Tylenol, ibuprofen, any of those medications that would impact the fever. It has to be 24 hours without a fever-reducing medication. Many questions have come in about children with allergies and asthma who may have a mild cough. So what about a cough? Well, it's pretty common. A child might arrive with a cough or a runny nose. We see those frequently. It's very common. Mild respiratory symptoms. This child, as long as they're behaving normally and they don't have fever, we don't recommend that there be any testing or exclusion from care in that situation. And this is consistent with the PA code and with Caring for Our Children best practices. So no, runny noses are not a reason to exclude a child. And so children with asthma and allergies that might have some of these symptoms, hopefully you would know that and that you wouldn't exclude them if they're having some of these mild symptoms. There is guidance if a child or staff has been tested for the COVID-19, and the CDC provides guidance for when to return in this document that is linked here. So I encourage you to take a look at it. I'm going to go through a few of the highlights right now. This is the CDC guidance for those who are tested for COVID-19. If you have had a test to determine if you are still contagious, you can leave home after these 3 things have happened, and all 3 of these must be met. You no longer have a fever without the use of medicine that reduces fevers, and you no longer have other symptoms. The symptoms have improved, for example, when your cough or shortness of breath has improved, and you've received 2 negative tests in a row, at least 24 hours apart. And doctors will follow the CDC guidelines on how to, really cover you for this based on your health history. It is very specific based on people's health history. So it's important to consult with your doctor. And if there are staff and children in the program that have been tested, of course, you'd want to confer with their doctor over the phone to make sure that all of these three things have happened. This is taken directly from the CDC guidance at this link on the slide. How to discontinue home isolation. This isn't the case if you have not had a test for COVID-19. And it's to determine if you are still contagious. And you can leave home after these three things have happened. You have had no fever for at least 72 hours. That's 3 full days of no fever without the use of medicine that reduces fevers. 72 hours is 3 full days. And there are no other symptoms. Your symptoms have improved. For example, your cough or shortness of breath has improved. And there has been at least 10 days that have passed since your symptoms first appeared. We know that it can take up to 2 days for the symptoms to appear with COVID-19, and then we want to have an additional 10 days that have passed after your symptoms first appeared. It can take up to 14 days also for symptoms to appear. So that's going to be quite a bit of time if you don't show symptoms until 12 or 14 days. It's going to take another 10 days after that. So it's very individualized based on when you show symptoms. And this is important to really consult with your physician about this and not make these decisions on your own. And again, here is the link to the CDC guidance on this. So please be aware that questions about doing the COVID-19 testing is really going to depend on the local testing capacity, the coronavirus disease incidence in the local area, the testing supplies that are available, and other factors. At this time, it appears that most or many people who want the COVID-19 tests will not be tested. So it's important to check with the person's doctor. We know that many or most people with coronavirus actually have no symptoms, also being known as asymptomatic. So therefore, it will be a fact that there will be some children and staff in the program who have had coronavirus that goes undiagnosed. And that's why it's so important to be very familiar with this current CDC guidance and to practice physical distancing, strict hand and respiratory hygiene, wear a cloth facial covering or mask, and adhere to other best practices around cleaning and disinfection. A lot of people don't necessarily know who's at risk for severe illness with COVID-19, and this can vary greatly from person to person, but people of all ages with any underlying medical condition, such as a chronic lung disease or moderate to severe asthma, serious heart conditions, immunocompromised, severe obesity, diabetes, chronic kidney disease, undergoing dialysis, and liver disease. These are all examples of people who might be at risk of any age, at any age. And we also know that we're beginning to learn that even adults under the age of 40 are having severe strokes, very serious strokes, as a result of being exposed to COVID-19. And some children are at risk for system-wide inflammatory responses, as I mentioned earlier, similar to Kawasaki disease. So it's expressing itself in many ways. And even though you might not have a health history, doesn't mean you're not going to experience severe illness from COVID-19. I wanted to review a few of the basics about COVID-19. These are just basic infection processes that happen with the virus, there's really only 3 places that the virus enters the body: through the eyes, the nose, and the mouth. You cannot get the COVID-19 if you're protecting your eyes, nose, and mouth. So it's very important that you not touch your eyes, nose, or mouth. And it's important that you protect yourself with the personal protective equipment that I'm going to talk about in a minute here. I wanted to show this picture, this photograph actually, of a child having a sneeze and what that actually looks like when you look at the particles that come out of the mouth, all of those droplets that are generated when a person coughs or sneezes. And so all of these droplets could be coming out, you know, if the child, even if the child's asymptomatic, they could be spreading this coronavirus into the classroom or into the home. And it's going to come out about 3 feet and probably begin to fall to the ground, which is why it's so important to maintain, if at all possible, the physical distancing so that these airborne droplets don't fall on you. And certainly we don't want them to fall into your eyes, your nose, or your mouth, which is why I'm going to talk about the masks right now. This is really important. It's important that adults and children over 2 years should wear a cloth face covering or mask that covers the nose and mouth. And when feasible, staff and older children should wear face coverings within the facility. Children over age 2, we know, may not be able to feasibly keep a mask on without frequently touching or removing it. And that actually does defeat the purpose of having a mask. So it's going to be important for the provider and the parent to decide if a mask is feasible for the child. And for children with a developmental disability, the parents need to decide if wearing a mask is feasible for their child. The CDC guidance actually does recommend the cloth face coverings that are handmade. And ideally, they're going to be washed daily. And it's best if you can to use the facility's washer or dryer. If that isn't available, then they can go back and forth to home, or they can be left in the child's cubby in a cloth or a paper bag overnight. This will help to prevent any further spread of the virus. Also, the paper masks can be reused. What you can do is put it into a paper bag, a brown paper bag overnight, and it will air out. As long as you put your name on the bag or the child's name on the bag. You shouldn't be wearing any cloth face coverings or masks when you're napping, eating, or exercising. So if children are running around outside on the playground, it's not necessary to have those coverings on. Anytime your breath rate is up with physical activity, it's not a good idea to wear a mask at that time. Of course, you would not want to put a mask on anyone who's really currently having trouble breathing or someone who's unable to remove the mask without assistance. Many people have asked questions about asthma and if that's okay to wear a mask if you have asthma. And my suggestion on that is to talk with the person's healthcare provider about it. People with chronic illnesses, as I mentioned earlier, such as asthma, are more at risk for complications from COVID-19. So we definitely want to protect people who have asthma as best we can. So adults certainly can assist children with managing the masks, and we would recommend that. Avoid touching your eyes, nose, and mouth when you have the mask on. Safe ways to handle it or to grab it by the edges, and adults can help with that. At meals and naps, you can place the mask on a name-labeled square paper towel on the table or the nap mat next to the child. You can also place the mask surface with the part that touches your nose and mouth face down, as that will protect it. And then, as I said earlier, the masks can be stored in a labeled paper bag out of reach. That's when they'll be able to be aired out and reused. Immediately after handling a mask, adults and children should hand wash or use the hand sanitizer, which is greater than 60% alcohol, with the adult supervision. These strategies that I just mentioned about placing the mask on the square of a paper towel is actually an example of a program level decision about how they're going to manage the masks. This is a picture or the link to the CDC resource, use of the cloth face coverings to help slow the spread of COVID-19 and how to make the cloth face coverings. There have been some questions about what staff should wear, what staff clothing should be available. And the CDC guidance recommends wearing long sleeves and hair up. Some programs have provided smocks to their staff. It's a good idea to have several backup long sleeve shirts and or smocks on hand. For example, if a child vomits or spits up on you, of course you would need to change your clothes because they're visibly soiled. One thing you could do is try to use a protective towel or bib to prevent that from happening, and definitely wear a smock over your clothing so you can easily take it off and launder it and then use something as a backup. You would want to use gloves to handle the clothing that's visibly soiled with vomit or urine or bowel movements or diarrhea. And if there are any children that happen to sneeze on your skin, like up on your neck or on your chest or something like that, and it gets on your skin, it's a good idea to use the alcohol wipes to wipe that area down, just in case there were any air droplets from the virus that landed on your skin. In the previous webinars, I've gone over a lot of the drop-off protocols that are outlined in the CDC guidance, and I'm going to quickly go through these in case there are some folks who are listening today who have not been through the webinars yet. It's important to plan arrival and drop off outside the facility, even curbside, to be separate from the facility, and to stagger the arrival and drop off times if possible. You're going to want to have people screened before they come into your program, before they enter the door. And you're going to be using hand sanitizers for the sign in and sign out by each parent. They need to wipe down the pen each time with alcohol, or you can help them wipe it down. You want to maintain 6 feet physical distancing. Hopefully, whoever is the designated person to drop off a child is also wearing a mask to protect their nose and mouth from droplets or from sneezes or coughs. And the person who's dropping off should not be a person who has an underlying medical condition or a person who is more vulnerable. And people in the category of 65 years or older are definitely more vulnerable. So we would suggest that you avoid having grandparents. Ideally, the same person is bringing the child every day so that they understand the process of drop off and the screening that happens. There are 3 methods for screening, which I'm going to quickly go through. The method number 1 is the social or physical distancing, when you must stay 6 feet apart. And this is understanding that the child's temperature is taken at home, and the parent or guardian is confirming that the child does not have a fever, cough, shortness of breath, or trouble breathing. You would still need to do a visual inspection of the child for signs of illness as part of your health check, including the flushed cheeks, rapid breathing, fatigue, or fussiness. Some of the considerations to think about if you're going to use family reported daily temperatures is Do the families actually have access to a thermometer? This is not necessarily the case. When they do research, they see that over 50% of families don't have thermometers at home. Do they know how to appropriately use a thermometer? Not all parents are consistently reliable when they're reading the thermometer, and many of them don't know what a precise measurement of a fever is. What is the exact temperature that they're looking for when you're asking them about whether a child has fever? You'll have to definitely give them these instructions. Not all of the parents will report a fever, even if a child has a fever greater than or equal to 100.4 degrees Fahrenheit. And we know that it's possible that the child has been given a fever reducer medication prior to drop off. These are fairly common happenings. For a family childcare home, I wanted to suggest a few things. The method number one, the child's temperature is taken at home and the parent or guardian confirms that before bringing the child to your home. Of course, you're still going to do a visual inspection. Some of the strategies that we've heard from family child care home providers is that they're screening children before they even leave home. And they're using FaceTime with the iPhone or Google Duo with the Android phone. They're observing the thermometer and the measurement of the child's temperature at home through the iPhone or their Android smartphone. They're observing how the parents take a child's temperature and offer guidance while it's being done. And they can also do a quick audiovisual health check of the child on their smartphone prior to the child even leaving home. So this is a really clever way of screening children, I think, before they come to your home. It's something to consider. Also with the family child care homes, very important to stagger the drop-off and pickup times with families, if at all possible. If two parents arrive at the same time, it's important to let them know this is your policy. One should remain in the car until the others finish dropping off their child. Do not hug or shake hands at drop off or pickup. Again, maintaining as much physical distancing as possible, and to have a designated person drop off or pick up who's not a vulnerable person. As I said earlier, that should be a part of your policies and procedures. So method two of the CDC screening method, this is the barrier or partition control. It's when the provider stands behind a physical barrier and makes a visual inspection of the child. Also conducts a temperature screening with a thermometer, which is ideally a no-touch thermometer, and using a clean pair of gloves for each child that you're assessing temperature, unless you're using a non-contact, no-touch thermometer. It's possible you could bump into that child's forehead with a no-touch thermometer, so it's a good idea to clean and disinfect the thermometer, even the no-touch type, between each use. And you can either do that with an alcohol wipe that's greater than 60% alcohol, or you can put a hand sanitizer, a dab of it on your glove, and then wipe off the end of that thermometer. Even if it's a no-touch thermometer. This is the third method. When you're wearing your personal protective equipment, you can get closer to a child and you can be within 6 feet if you are wearing your mask and cloth face covering. And it's actually recommended during the screening time outside the facility that you're using eye protection, such as a pair of sports goggles or shop goggles that you get, at Lowe's or Home Depot. They're not very expensive. The regular glasses are not enough because these goggles need to cover all sides of your eyes, tops, bottoms, and sides. And the purpose of that is to prevent anyone who's sneezing or coughing, to prevent those droplets from getting into your eyes, which is, as I said earlier, one of the main ways that the coronavirus gets into your body. Use the disposable gloves and possibly a smock or gown with long sleeves while you're doing this, while you're doing your screening of each child. You're going to take the child's temperature and visually inspect the child against those signs and symptoms that I mentioned earlier. And then as soon as you take the child's temperature, you're going to use that hand sanitizer to wipe it off at the end. There have been questions about the ratios. We know a lower ratio is better than a higher ratio in limiting the risk of exposure to the coronavirus. The CDC guidance recommends maintaining the makeup of the groupings by not mixing groups once established, and by maintaining the same caregivers and providers, staff members for each grouping to avoid additional exposures. So not going back and forth between rooms, that should be avoided. I'm hearing that providers may not take infants and toddlers due to the required ratios. But it's good to remind them that although the guideline does suggest a lower ratio, they may still operate by maintaining ratios that are required by the Pennsylvania Code licensing regulations, which are currently 1:4 for infants. So a potential exposure to the coronavirus means being a household contact or having close contact within 6 feet of an individual with a confirmed or suspected COVID-19 for at least 10 minutes. The time frame for having contact with an individual includes the period of time of 48 hours before the individual became symptomatic. And as I said, it can take 2 to 14 days for someone to become symptomatic. And we've even heard of cases that can take up to 21 days before someone becomes symptomatic. So it's a long time frame to be thinking about and very specific. So if there's any question about exposure, we definitely recommend that you call the Pennsylvania Department of Health at 1-877-724-3258. If there's a positive case of COVID-19 in a child or an adult who has been present in the child care facility or the family child care home, or if there's a family member in the home who has tested positive, it's important to call the health department to learn about how there can be contact tracing done to make sure that whoever was exposed is being managed properly, or anyone potentially exposed is managed properly. And this varies greatly based on the location you're in and the population density of the county that you're in, and just how many circulating viruses are happening in your local area. And it does vary. So it's important to call the Pennsylvania Department of Health to ask for that guidance. And also call your healthcare provider or encourage that person or adult or family member to call the child's healthcare provider for specific guidance. Any kind of discussion with a healthcare provider is going to be helpful at this time. It's also important to inform OCDEL by contacting the appropriate regional office of certification. So again, I just want to ask you to please email your questions. And if I didn't address your question today in this third webinar, I'm going to be doing them on a weekly basis. So if you could just send me another email with your question, I'd be happy to try to address it in the next webinar. The guidance is very lengthy and very detailed. It's 8 to 10 pages of guidance. So it's just not possible to address it all at one time. But I'd be happy to address your questions, so please send it. The webinar topics are new every week to address these questions, and if there's any changes to the guidance. And almost every day there's some new guidance that comes along that we need to be thinking about and be aware of. OCDEL is committed to reviewing and addressing all the questions to the best of its ability. And again, here is the email address to send your questions. hssco@pakeys.org. Thank you so much for listening, and please stay safe and healthy out there and stay in touch. Thank you.